Hello everyone, in this video will talk about central serous chorioretinopathy CSCR. So, what is CSCR? It's a chorioretinal disease that causes an idiopathic serous detachment of the retina. The pathogenesis of CSCR remains poorly understood. However, choroidal abnormalities are believed to be the primary underlying pathophysiology. These abnormalities can include choroidal thickening, choroidal hyperpermeability, increased hydrostatic pressure. All of these abnormalities together results in detachment of the retinal pigmented epithelium. The risk factors of CSCR are: men are 8 times more likely to develop CSCR compared to women. Corticosteroid use, which is the most important external risk factor. Type A behavior, in which they have a personality traits that include an intense, sustained drive to achieve self-selected goals. Interestingly, individuals with type A behavior are believed to have increased levels of corticosteroids. Pregnancy is thought to be caused by hormonal changes that can induce vascular changes in the choroid. Uncontrolled hypertension will lead to choroidal vasculopathy. The signs and symptoms are sudden onset of blurred vision, decreased color vision, paracentral scotomas, metamorphopsia, in which the shape of objects appears distorted, micropsia, where the objects are perceived to be smaller than they actually are. CSCR is commonly divided into 2 categories based on the duration of symptoms: the extent of leakage on angiography and the presence of retinal pigmented epithelium atrophy. Acute CSCR, defined as an acute onset, dome-shaped serous detachment of the neuroretina. Fortunately, most of patients with acute CSCR will have spontaneous resolution of the resulting subretinal fluid in 3 to 6 months together with a good visual prognosis. The OSET image shows presence of foveal subretinal fluid overlying a thick choroid. Chronic CSCR, characterized by serous detachment of the retina and retinal pigmented epithelium together with atrophic changes to the outer retina. Unfortunately, patient with chronic CSCR will experience persistent serous detachment on OSET for longer than 4-6 months, which leads to permanent structural damage in the neuroretina with irreversible long-term vision loss. OSET image shows subretinal fluid, photoreceptor outer segment atrophy, a small retinal pigment epithelial detachment, and choroidal thickening. To diagnose CSCR, we have different modalities: optical coherence tomography, fluorescein angiography, fundus autofluorescence, indocyanine green angiograph. Typical fluorescein angiography include the ink blot appearance and smokestack pattern. The commonly used in practice is OSET. Images here demonstrate the subretinal fluid and pigment epithelium detachment. You must wonder by now how to treat. First of all, we should start with eliminating the risk factors, such as discontinue the use of all forms of corticosteroids. Lifestyle modifications and stress management for type A behavior. An acute CSCR observation during the first 3 months is the most widely used strategy because of the high rate of spontaneous subretinal fluid resolution. Unless personal preference for treatment such as professional reliance on optimal vision indicate rapid intervention. Bilateral disease activity. Recurrent episode. If the subretinal retinal fluid persists or treatment is indicated, the current evidence suggests that photodynamic therapy is the treatment of choice. In case it's not available, there are other options, which include laser photocoagulation, subthreshold micropulse laser, mineralocorticoid antagonists. The most commonly used treatments for chronic CSCR is photodynamic therapy. If persistent subretinal fluid on OSET, there are other options, such as antivascular endothelial growth factor, subthreshold micropulse laser, mineralocorticoid antagonists, repeat photodynamic therapy. Observation.